And so we'll start off again going around, and if you wouldn't mind just introducing yourself, a couple sentences about who you are and what your practice is like. Dr. Garley?
Hi, Alan Garley. I did my residency at the condominiums formerly known as St. Vincent's Hospital Medical Center in New York City, which is now closed. I did my fellowship in urogynecology and pelvic reconstructive surgery at LSU in New Orleans. And I am the chairman of OBGYN at Mount Sinai South Nassau, which is one of the three main teaching hospitals for Mount Sinai Health System.
Wonderful. Dr. Gainesman-Tan?
Yeah, hi. I'm Jules Gynecologic. I'm an assistant professor at Northwestern University, and I'm a female pelvic medicine reconstructive surgeon. I did my residency in New York City at Cornell University or New York Presbyterian, and my fellowship at Northwestern, and then stayed on.
Wonderful.
I'm Dr. Shen.
Okay, go ahead, Dr. Shen.
Okay, I'm Jenta, Jenta Shen, as at EN San Francisco. I'm a clinical professor at the UCSF. My subspecialty is on GYN oncology.
Welcome, and thank you for being here. Dr. Mueller?
Hi, I'm Maggie Mueller. I am also a urogynecologist. I did an OBGYN residency at the University of Chicago and then went on to finish a fellowship in female pelvic medicine and reconstructive surgery at Northwestern. I'm currently the program director at Northwestern University. I work with my esteemed colleague, Dr. Gynecologic, and before she was my colleague, she was my fellow. So we're very excited to talk to you guys tonight and share a little bit about our field.
Wonderful. Well, thank you all so much for being here. So babies, right? But there's a lot more than babies to OBGYN. So maybe we keep hearing this urogynecology, and what is that? And, you know, isn't it all just babies and whatnot? Dr. Garley, can you fill us in?
Sure. Before the specialty of urogynecology was started, general OBGYNs used to take care of everything. They would do cancer surgery, infertility, and take care of patients who had vaginal prolapse and incontinence. But as the field developed, we started to have subspecialties, and then oncology started, MFM, and then urogynecology. We're the last one of the subspecialties to be boarded. We specialize in pelvic floor disorders, incontinence, prolapse, fistulas, complex pelvic pain, complex surgery, revision surgeries, and most of us are pretty limited in the scope of our field. Most of us don't do general OBGYN. Dr. Mueller, you think I have anything to add to that?
I think you're pretty, that was pretty comprehensive. And yeah, I think there's sometimes it has a tendency to refer to our field as OB and leave the GYN part off, but there's actually a lot in GYN. As Dr. Garley mentioned, GYN oncology, reproductive endocrinology, urogynecology. There's a newer subspecialty, complex family planning. So there's really a lot of women's health issues that can be addressed through an OBGYN subspecialty.
And as Dr. Garley mentioned, my understanding is, and correct me if I'm wrong, that it was really the gynecologists that pioneered most of the surgeries that we do within the abdomen and within the pelvis, and were the first to be doing laparoscopy and to be doing minimally invasive approaches, and really pioneered a lot of what is carried on into other specialties. Can you talk a bit, maybe Dr. Gynecologic, a bit about what kind of operations you do? What are the things that make up your practice?
Yeah, of course. So I think of us as complex pelvic surgeons for all kinds of women's health issues. So most of us, I think I speak for certainly everybody on this call that does urogyn, we take care of everything from vaginal prolapse, uterine prolapse, incontinence, fistulas, whether those are rectovaginal or vesicovaginal, ureterovaginal. We do some lower urinary tract injury work. Dr. Mueller and I together do a clinic for congenital anomalies of the genitourinary system and reproductive tract. There are people in our field who do things like they're part of trans care or female genital mutilation or circumcision repairs. So all kinds of different things on the spectrum of pelvic reconstruction.
Very complicated stuff. What are some of the just straightforward run-of-the-mill, what's the bread and butter of a practicing gynecologist? Dr. Mueller, maybe you could tell us a bit about that.
Well, I'd say for the specialty, I'll try to speak a little bit more broadly on what a practicing OBGYN would be doing. And as Dr. Garley mentioned, we have developed specialties or subspecialties within our specialties. So it has really kind of directed where people get their care. So most cancer patients are going to receive care with a GYN oncologist. A patient who has fertility issues is going to seek care with a reproductive endocrinologist. But I would say a general OBGYN is really kind of the keeper of women's health. So first line, almost primary care for women's health, pap smears, workup for abnormal bleeding. There's a lot of adolescent gynecology that can be developed in a general OBGYN practice. Really the gamut of preventive women's health care. I would say that for a practicing urogynecologist like myself, and when we were talking about bread and butter surgical procedures, we're really talking about anything that's treating incontinence or urinary leakage, bowel leakage, or prolapse, things falling down out of places where they shouldn't be. So vaginal prolapse, rectal prolapse, et cetera. That would be basically bread and butter for a practicing urogynecologist.
And so those sounds like things that the colorectal surgeons would do, which is how we're sort of dovetailing all this together tonight. So Dr. Garley, can you talk a little bit about your collaboration with other specialties? Who else do you get to work with? Do you get to work with colorectal surgeons, which must be just an absolute treat for you?
Absolutely. And in fact, my colorectal colleagues are probably my closest friends in terms of people I not only work with, but people who I socialize with. We overlap in many ways, and a lot of things that were described by your colorectal surgeons earlier really epitomize the relationships that we have in urogynecology, and that we are a really friendly group. We're mostly, we like to get together. And that's why I think we get along with the colorectal surgeons so well, is because we have a lot of similar personality traits. We do a lot of we have actually more than combined cases. We actually have a consortium where we see patients in collaboration together, because patients that have a lot of prolapse issues also have fecal incontinence, internal rectal prolapse, external rectal prolapse. And rather than subject patients to multiple surgeries, we tend to do these things together.
Sorry,
and we have a lot of
here this past Saturday.
Dr. Shen, I think you need to mute. Okay. Anyway, yes, we do a lot of collaborative stuff together, and it really makes a huge difference in the patients. Also, when we do rectal vaginal fistulas, a lot of times we will do those together. We do them with plastic surgeons. Most of the work that I do is usually in collaboration with plastics and with colorectal. Not so much with general urology, because the way I was trained, we had a lot of overlap with urology, so we tend to do a lot of urologically based procedures ourselves.
Really a lot of collaboration, a lot of interesting operations, and it sounds like a lot of creativity in coming up with solutions to very difficult problems. Dr. Shen, can you talk a little bit about the GYN oncology specialty and the kinds of things that you do, and what do you take care of? You are muted if you're trying to speak. Oh, he may be tied up. So maybe we can, I'm sure
Can
that
you hear me now?
Oh yeah, there you are, Dr.
Can
Shen.
you hear me now?
Yep.
Okay, good evening. Yeah, I'm practicing in San Francisco. I did my residency OBGYN at the UCSF. and GYN oncology at USC Women's Hospital in Los Angeles. I was on faculty at Columbia, and now I'm back in San Francisco. What we do is a radical surgery for GYN cancer of cervix, uterus, ovaries, vulva, and vagina. We also give chemotherapy. And for the requirement of treating GYN cancer, we can also do colorectal surgery and urological surgery as part of training and part of practice. In addition, we also give chemotherapy. So a very comprehensive program.
And that last part, the chemotherapy, that's pretty unusual, right? There aren't very many surgical specialties that are prescribing and delivering their own chemotherapy. Talk about that
Exactly.
and how that's part of your practice.
Yeah, that became sort of very unique among the surgical oncology specialties. GYN oncologists had training of chemotherapy, not as comprehensive as medical oncologists. But if you look at the practice and the literature, most of the GYN cancer chemotherapy all provided and reported by GYN oncology teams. But more and more medical oncologists are also involved. So this is a very unique oncology specialty. For those of you who are interested to this comprehensive program, certainly GYN oncology is the way to go. You give own chemotherapy.
Yeah, so that is, like you said, very comprehensive. Although I'm hearing from our urogynecology colleagues as well that they're doing urology and colorectal, and everyone's really doing a lot of complicated stuff. So let's back it up and talk a little bit about why did you choose OBGYN? So Dr. Gynecologic, when did you realize that that was going to be your specialty, and what was it about it that drew you in?
Sure. So I initially wanted to go into OBGYN because of the social justice issues, right? I believe that for a long time, women have had disparate care, and I love the fact that you could take care of a woman throughout the entire length of her life. You know, that OBGYN really starts as soon as babies are born, and you take them through adolescence and through their childbearing years and menopause and postmenopausal years. And so I love that aspect of it. And doing an OBGYN residency, I realized that, you know, as much as obstetrics is fulfilling and exciting at times, I really loved being in the operating room. And I didn't get to do very much of that, obviously, during obstetrics, apart from C-sections. And so I really wanted to develop my skills as a surgeon. I specifically really like urogynecology as a field because it gets back at that social justice issue of quality of life. You know, I think that so many of our patients, like I think Dr. Beatty was saying earlier, you don't have to be saving lives in order to really make a huge impact. I think for so many of our patients, they don't work or don't take care of their families as well, or, you know, just really cannot enjoy their quality of life as a result of their pelvic floor disorders. So that's been really rewarding to me.
Yeah. And again, hearing about a very holistic approach to care, being able to really deliver a lot of elements of care, not just surgical, but medical and social. I will just remind our live participants to please feel free to use the Q&A if you have questions you'd like to ask of our panel. And Dr. Shen, if you wouldn't mind just muting a little bit, there's some background noise. We'll reach out to you or let you know when to unmute. Dr. Mueller, what about you? What was it that drew you to the specialty? When did you decide, and why the subspecialty pathway that you selected?
Oh, so my pathway is a little different than Dr. Gynecologic. I started my third year of medical school. I absolutely knew the last thing I wanted to do was OBGYN. I was pretty sure I wanted to be an ENT surgeon. And while I have a ton of respect for all ENTs, I have some of my best friends are ENTs. When I was in medical school, I was placed on the ENT service at the VA hospital, and I didn't find it as exciting as I thought I would have. So I knew I did like surgery. And when I went into my OBGYN rotation, albeit I again knew I wasn't going to want to do that, but I kept an open mind, and I was lucky enough to be on a rotation called urogynecology, which I'd obviously not really heard anything about. And I was really drawn to that. They had the cool surgeries that I was interested in, but more importantly, I think Dr. Guinness-Mintan spoke to this. It was really focused around quality of life and improving quality of life. I loved that in comparison to GYN oncology, where it was a very heavy field. There's always a lot on the line. The quality of life disorders, fixing that with a small, simple procedure was really something that drew me to that field. So that was kind of my circuitous pathway. I have nothing against obstetrics. It just wasn't really drawn to that. So I did grin and bear it, a residency program of obstetrics and gynecology. As you probably identified, the surgical subspecialists nowadays don't practice obstetrics. There is another way to approach urogynecology. You could go through a urology residency, and we take fellows every year in urology, just like we do in OBGYN for our fellowship. There is a joint fellowship with either pathway, similar to some other surgical subspecialties.
Dr. Garley, can you talk a little bit about the research that's going on in OB/GYN, and also if a student is interested in pursuing the specialty, do they need to do research?
So the competitiveness of OB/GYN residencies right now is out of control. And the last statistics that I've received as of yesterday were there are 1,500 OB/GYN spots. There are 2,500 applicants, 1,500 US will be graduates, 500 osteopaths, and 500 international medical graduates. To be competitive for a good program, you definitely have to have some research. For programs that don't usually take AOA students, I would say it's helpful, but not required. Some of the research that we're doing, the really cutting edge stuff right now, are based on regenerative medicine and stem cell type work. Of course, a lot of people are doing work in drugs and also in new reconstructive techniques.
Sounds like very exciting and cutting edge stuff, a lot of opportunities. I think when a lot of students think about OB/GYN, they're not thinking so much about big complicated surgeries. Other than urogyn and gyn-onc, what are some other specialties within OB/GYN that are mostly surgical?
Well, oncology for sure is the most surgical. Our reproductive endocrinology has really laid off a lot of the surgery issues, and they're more based in the office. Pediatric gynecology is taking some of the congenital anomalies, and I'm happy about that because I think that they are really well suited for that position. I don't know if any of the other urogyns think of some other fields that I'm missing.
I would just add that you can go through a general OB/GYN residency and devote most of your generalist practice to being a surgeon. There are plenty of people who just focus on doing hysterectomies and hysteroscopy and kind of the general bread and butter of general gynecology without doing a subspecialty. And of course, there's a fellowship in many places in minimally invasive gynecologic surgery. And so those people are doing, endometriosis cases, complex ovarian cyst type cases that are benign in nature. So certainly you could make that a big part of your practice.
So Dr. Mueller, you're program director, and so you're involved in the selection of who's going to join your training program. There's a question from the chat about, let's say that you started down the pathway of general surgery, or some other specialty, and then you finally get that experience like you had, you get to do the rotation and you love it. Can you change lanes like that, or do you have to take extra time in med school, do extra research? How do you, if someone decides late that they want to become an OBGYN, can they do it? What do you recommend?
I think you definitely can do it. As everyone's kind of mentioned, I think that what most residency program directors are looking for is an interest and a commitment to women's health. So one of the easiest ways to get involved is, if you found that surgical subspecialty like GYN oncology, if you approach some of your GYN oncology faculty, fellows, or residents about potentially participating in some research, I think that's a great way to do it. It's never too late to do that. I mean, it might be too late if you've already applied, but I certainly know a lot of folks that changed their minds. They wanted to go into emergency medicine, and at the last minute, they changed into OBGYN. So I think as long as you've got that passion and that drive, you'll be well suited.
That's great to hear. Dr. Shen, can you talk a little bit about what is the pathway like from medical school to become a GYN oncologist? It sounds like it must be a lot of training to do all those different elements of the field.
Yes. You certainly can go through 4 years of OBGYN and then go into G1 oncology. But sometimes you can have a 1 year in surgery or 1 year in medicine and 3 years in OBGYN, but you can request reducing the OB part and spend a little time on G1 or G1 oncology. But it is very competitive to get into a good G1 oncology program. So it would be advisable to have additional research starting in medical school or in OBGYN residency. The fellowship requires 2 or 1 at least 1 year lab before going into a clinical part. And that's because a lot of practice is involved with chemotherapy and precision medicine and targeted therapy, those kind of very modern equivalent to a medical oncology. So you can, you certainly can delegate the medical therapy to the colleague in medical oncology. If you belong to a major managed care system, you may not want to get too much involved with chemotherapy. However, that's the unique part of G1 oncology. So for those of you, the student who are looking into this field, can go into more molecular research or a little extra surgery or even medicine to come to this field. It's wide open. And by the way, as you know, OBGYN welcome more and more the lady participants. Same for G1 oncology. Our society is seeing major increase of ladies as the active members and practitioners. So this is a major change.
Great. So
Yep.
we asked the colorectal surgeons, so now I'm going to ask you all to talk about what are some of your least favorite parts of the specialty. We've heard a lot of the good and a lot of the fun things. So Dr. Gainis-Mintan, what's some? Oh, I got a smart. You don't want to answer. That's okay. I don't want to put you on.
No, I can answer. I just couldn't think of anything.
You can think of anything you don't like. That's fantastic. That's like a classic letter of recommendation answer. Right?
My greatest weakness is that I like everything.
She also never says no.
It's true. I don't know. Let's see what Dr. Mueller has to say. Let me think on it.
Are we talking about the specialty of OBGYN or the subspecialty of urogyn?
It can be either way. What are some things, a student who's going into this, we want them to have eyes wide open. So what are some things that they should be aware of that maybe are not as wonderful?
So I would say that, general OBGYN is a field of women's health, preventive care. There is some overlap with, primary care, medicine aspects. I think that if you are going to struggle with that, that's going to be something that you might not like. I'm not saying that we're treating hypertension and things like that, but there are some definite preventive care, primary care overlaps. I personally, I already mentioned it, I didn't love obstetrics, so that was difficult for me. But even if you don't love obstetrics and have a calling for obstetrics, it's just 4 years. And there's a lot of gynecology involved in an OBGYN residency. So those are the things that I, wanted to minimize during my residency.
Dr. Garley, you want to share anything that maybe is not the best part?
Sure. The worst part of what we do every day is anything that's not surgical. And because I'm the oldest person on this entire forum, I have the right to give all the patients that have urinary tract infections and chronic pelvic pain to my junior partners, which would be Dr. Geinesman and Dr. Mueller if they were working with me.
Yeah, we could have summed it up in UTI.
Okay, that makes sense. But I think what I'm hearing is that there's a lot of different ways to go within OBGYN. And so someone who does have that passion for primary care, specifically women's health primary care, could really find a whole world of opportunity there. Whereas someone who that's not their interest, they're more interested in the operative elements of women's health, can find a lot of different areas to specialize in there as well. So really very broad opportunities. Dr. Shen, did you want to share anything from the GYN oncology world that maybe is not the best part of your job? Or maybe we can throw it back to Dr. Gynecologic if you thought of anything you wanted to share. Or we can we'll give you the converse. You could say what is the absolute best part of your job?
Oh, the absolute best.
Can you hear me now?
Oh, yes, go ahead, Dr. Shen, and then that'll
Yeah,
give Dr.
sure.
Gynecologic
Okay.
a moment to think.
Sorry, because my system is not working well today. Anyway, in G1 oncology, it's a field of challenge. So we provide cancer care. So we feel positive in being able to cure cancer. On the other hand, though, this is a field we sometimes fail. So we have to deal with patients' failure from treatment, and we are dealing with more of death. So that's the challenge or negative part of our specialty. And so for those of us, we certainly would have to realize that from the beginning. But other than that, we enjoy our work, and we certainly welcome students who want challenge, surgical practice, medical oncology, and research. Thank you.
Great. So Dr. Gynecologic, we'll give you the last word. What is the best thing about being an OBGYN, specifically urogynecologist? Why should our students follow in your footsteps?
Yeah. I mean, I think that what I really love about all of OBGYN, but my field as well, is that every day is different. And if you're somebody who has a little bit of, ADD, or just, wants to conquer the next frontier or do something different all the time, that's what I love about it. I mean, there are no 2 weeks that look alike between clinical care and teaching and research and advocacy. Everything looks different week to week. And I think the target on women's healthcare is constantly moving. And I think, like Dr. Garley had said, our field is rapidly evolving, especially in the aspects of regenerative medicine. And that's something that's really new and exciting for us. And so I think it just gives me a lot of hope, and it's very creative every day to do this job.